So welcome everyone. Thank you for joining us for the session titled Leave No One Behind, Ensuring Inclusive NCD Responses, co-hosted by NCD Alliance and Merck. My name is Patrick and I will be your technical facilitator today. For assistance, please do use the chat function to message anyone with the title technical facilitator in their name. Before we do begin, I do have a few technical notes to explain. If you would like to contribute a perspective, idea, or thought, please do use the chat function. You can find this feature at the bottom of your Zoom window. If you would like to post a question, please do use the Q&A box, which is also found at the bottom of your window. Lastly, this session is also being recorded for documentation purposes. And we are also live streaming on Facebook in order to reach a larger audience. So again, thank you for joining us and welcome to the event, Leave No One Behind, Ensuring Inclusive NCD Responses, co-hosted by NCD Alliance and Merck. I will now pass the floor to our moderator for today, Ms. Katie Dane, CEO of the NCD Alliance. Ms. Katie, the floor is yours.
Thanks very much and good morning, good afternoon, everyone, and welcome to this event co-hosted by the NCD Alliance and Merck, entitled Leave No One Behind, Ensuring an Inclusive NCD Response. My name is Katie Dane, I'm the CEO of the NCD Alliance, and it's an honour for me to be moderating this event today. We're joined by a fantastic panel of speakers from all over the world. Before I hand over to them, I'll be providing a little bit of context on what the event will be focusing on, as well as the objectives of today's session. Over the last decade or so, as many of us are very aware and have worked towards, there has been a significant amount of progress in getting NCDs recognised by governments as an urgent global health and development priority, as well as setting the global policy response and architecture for NCDs, in strengthening the package of solutions and interventions that work to prevent and treat non-communicable diseases, as well as inspiring action at the national level and building a strong civil society movement that brings together this broad community across multiple diseases and multiple risk factors. The global NCD policy response over the last decade has very much been driven by WHO's 4x4 approach, which includes 4 diseases: diabetes, cardiovascular disease, cancer, and chronic respiratory disease, as well as 4 major risk factors that really underpin these 4 major diseases. And then notably that this approach, this 4x4 approach, evolved in 2018 to what's called a 5x5 approach, which now includes mental health as a 5th disease and air pollution as a 5th risk factor. But importantly, and this is something that the NCD Alliance has been consistently advocating for, these 4 or 5 diseases are linked to a much broader web of conditions and diseases, including endocrine-related conditions such as thyroid disease, as well as kidney disease. And it's estimated that 55% of NCD morbidity globally is actually due to NCDs that are outside of the original big 4x4 NCD paradigm. It's estimated that 1.6 billion people are at risk of thyroid diseases, and this disease has multiple connections to many of the big 4 diseases that I've mentioned in the NCD agenda, particularly in terms of diabetes and cardiovascular disease. And furthermore, what we're seeing is that the reality around the world is that multi-morbidity is now the norm rather than the exception. And so people are living with multiple different conditions and diseases at the same time. And often they're having to seek separate services for different conditions, noting that access and the cost borne out of pocket varies for different health conditions, adding to the expense and stress of living with these conditions. And so integrated holistic approaches and people-centered approaches make sense for non-communicable diseases, as well as ensuring that governments are really walking the talk on the Sustainable Development Goal principle of leaving no one behind. So the event today will build upon a policy brief that the NCD Alliance developed at the end of last year and launched, which really spotlighted endocrine health with case studies on thyroid disorders and kidney disease. And the event will really aim to explore the needs and priorities of people living with a broad range of NCDs with a particular focus on thyroid. Secondly, to be sharing best practice from country and global levels, which address these broad needs and priorities. And also to be highlighting recommended approaches to ensure a more inclusive NCD agenda at global and country levels. So with that context in mind, we will now move to our panel of expert speakers. And today we're joined by 6 speakers from around the world, spanning different sectors from WHO, private sector, governments, academia and civil society. And I'm really pleased to introduce our first speaker, who will be Andre Musto. Andre is Senior Vice President, Head of Global Cardiovascular Metabolism and Endocrinology at Merck, who is obviously the co-host of today's event. Andre will be sharing some of the key messages from the publication I just mentioned, Leaving No One Behind, Ensuring Inclusive NCD Responses, and focusing specifically on endocrine-related conditions, that was supported by Merck. So let me hand over to Andre for your intervention.
Thank you, Katie. You can hear me okay?
Absolutely fine, thank you.
Thank you. I just said thanks very much. It's great to be part of this panel, and it's a really important topic to discuss. And we at Merck are very passionate and committed to really helping and working with everybody here to make a real difference in many millions of patients' lives who suffer thyroid disorders globally. So I just got a couple of slides. So first slide, please. Thank you. So next slide, please. So I work for Merck Healthcare. So Merck is basically, it's a global company, 58,000 employees globally. We operate in 66 countries. Very quickly, we're known as Merck. Outside of the US and Canada, where Merck Sharp and Dome, MSD, is known as MSD. However, in the United States, a little bit of complexity. We're known as you can see at the bottom, EMD Serono. We also have divisions in life sciences and electronics. Next slide, please. We operate in 4 therapy areas: immuno-oncology, oncology, fertility, and neurology and immunology. And then the franchise that I look after globally is our cardiovascular metabolism and endocrinology franchise. And with which Katie has basically said earlier in the 4x4, the cardiovascular and diabetes, of which we also are very actively engaged as part of the NCD. So next slide, please. Now, here we have a real purpose and mission to bring better health to every single cardiometabolic and endocrine patient, helping them to live life to their full potential. And as you rightly say, Katie, there's so many interrelated areas here with people suffering not just cardiovascular issues, but not just endocrine issues, but also diabetes. And there's such a interlink here. And patients, many patients, when we look at the thyroid disorders, are suffering and they don't know they're suffering. So next slide. Here we come some of the statistics around thyroid disorders. We know that there's around about 1.6 billion people worldwide who are thought to be at risk of some type of thyroid disorder. It is proportionally weighted also towards women. 1 in 8 women are likely to develop thyroid problems during their lifetime. And yet thyroid disorders such as hypothyroidism are not yet considered as an NCD. And this is one of the, obviously, the critical things that we as a company, working with the cross-functional stakeholders, multidisciplinary stakeholders, are very eagerly trying to ensure that billions of, more than 1 billion patients globally can actually benefit from treatment, whatever that treatment is. Next slide, please. So we have high impact and low recognition here. We do a lot of research internally, and this, what it shows is that a number of things. The professional awareness is very low in some countries, and mainly in the emerging markets. Week before last, I was in Latin America, and I was talking with a number of specialists, and I was asking them specifically around why is the diagnosis and treatment so low in so many areas? It's not mainly in the hospital areas, it's not with specialists, it's the primary care physicians. There's lack of awareness on how to treat. There's a lack of awareness on when a patient walks in, is a TSH test part of a normal standard panel of blood tests. So there's a big issue in certain countries directionally, certain regions directionally, we have 20 to 30% of total patients that are either diagnosed and treated. So there's a massive, massive number of patients. We don't know the exact number because down the bottom left, you see the data collection and research and funding is really lacking in this area. We need government support to really step this up so we get a lot more data. And when we have more data, as physicians and scientists know, we can actually apply treatment algorithms and treatment practices in a much more sophisticated manner. There's also an issue around lab capacity and testing. We as a company in certain areas are now providing testing facilities for clinics. So what happens when a patient comes into a physician, they can actually get the TSH test there and then. And this is trying to make a difference to patients' lives. Because what we've also found in many countries globally, the patient will get the referral to a lab, and then they don't go, either they don't go to the lab and get it filled, or they don't go back to the primary care physician. So we've got a multiple of issues here when it comes to diagnosing and treating patients globally. And my last slide, please. Thank you. And so, as the NCD policy brief states, the challenge is not only to gain political recognition and support, but also to guarantee implementation of proven policies and actions and mobilizing sufficient investment. And that's really important that we get sufficient investment of this very important disease to really impact patients' lives positively. This requires a multi-stakeholder response at a global, regional, national, and local level. So we at Merck are very proud to be working in this therapy area to positively impact millions of patients' lives. Currently, we serve estimated around about 40 million patients globally through our medications being prescribed across the world. And we believe that this makes a positive impact. We are here to help and to work with you. Thank you very much. I hand back to you, Kate.
Thanks very much, Andre, for setting the scene on the challenge of thyroid diseases and also some of the barriers and the specific solutions that we're looking to fast track and accelerate globally and nationally. Let me now pass over to our second speaker, who is Dr. Slim Slammer, who is the Head of Unit for NCD Management at the World Health Organization. Delighted to have you join us today, Slim. I want to ask you a specific question, really, from where you sit in WHO. How have you seen governments making steps towards this inclusive NCD agenda that we're talking about today? And what do you think that the next steps should be globally, given that not too far down the road, we have the next UN high-level meeting on NCDs in 2025?
Thank you, first of all, Katie, for the invitation and for the team of the NCD Alliance for giving us the opportunity to contribute. I think you alluded to it in your introduction. First is to set the scene in terms of the context. As you have highlighted, we are less than 3 years before the next high-level meeting on NCDs. And as you know, I mean, since 2011, this has been a kind of milestone moment where we're reviewing progress, and we just submitted before the executive board of WHO last January a report on the progress. And unfortunately, I mean, few countries and less than 14 countries are on track to meet the SDG target 3.4 to reduce by 25% overall mortality of NCD. So there is again, and we have done it, and you have contributed over the years to maintain that momentum and a wake-up call on this 4x4, 5x5 approach, which is when we are discussing inclusion, is also prioritization based on burden, but clearly is not exclusion. And when we replace the discussion, and this is perhaps my first statement, is that we are within a wider scope of universal health coverage. And universal coverage is not everything, but is a progressive realization where countries are making also decisions and prioritize according to their own context in terms of epidemiological burden, trends, but also capacity. And this is a political process that all of us influences. And the work that has been conducted in parallel, both on the NCD, but at a larger stage on the universal health coverage, including some of the support and the influence that WHO have had on, for instance, supporting countries in developing national service package and UHC agenda, including with the work on the compendium, is that inclusiveness, I think, is probably broader than what we are discussing. And there has been a choice endorsed by member states to focus primarily on those conditions that are still the main killers, and cardiovascular disease at large, chronic respiratory disease, but also, I mean, diabetes and other endocrine-related conditions that are they're causing, I mean, the most important burden in terms of mortality and morbidity. But it doesn't mean that we are neglecting the other element of the agenda. You refer them into endocrine and specifically on thyroid condition, but also kidney disease. And we have been working also with partners like International Society of Nephrology and other partners to support, I mean, the inclusiveness and the work that has been conducted so far is still, and you were asking about the Appendix 3 specifically, which is this list of policy options, both at the population level for preventing exposures for NCD risk factors, but also reducing the impact of the most common conditions through healthcare-related intervention. This list is being updated and will be in consultation. The mandate that was given from member states to update that list is within the scope of the Global Action Plan on NCD, so still on the 4x4. But as I mentioned, the UHC compendium and the work at the country level goes beyond that. All national entities still have to respond to various needs that are beyond the 4x4 or the 5x5. Just to give you also an example, even in emergencies, we are very much involved in the Ukraine response. I was myself in contact with the European Society of Endocrinology and the colleagues working in Ukraine. These needs are there. There are people that need to maintain continuity of care for deteriorated conditions and beyond. So I think we shouldn't have a discourse that is reductionist in the sense that, yes, there is a global strategies that are there, maintaining the focus on cardiovascular disease and the most common killers. But in many regions, including in the African region, the tail of the NCD is longer and they are in different conditions. It's just a question of how we prioritize and how we engage into the discussion. What is important at this stage, as I mentioned in the introduction, is that we are less than 8 years, before the SDG deadline and few years now for the next high-level meeting. On the road to the 2025, as we call it, we have supported countries by developing what we call the implementation roadmap. That is really a plan on how countries can better review their progress based on their own epidemiological profile and capacity and try to accelerate action on NCD at large. It doesn't mean that some other condition could not be included, and there have been different alliances, and NCD Alliance was part of a secretarially health alliance that bring together different professional associations looking at cardiovascular disease at large. I think we could have similar alliances where we bring a more comprehensive response at the national level. But again, for me, what is important is to tailor those discussions at the level of the countries. The countries have the sovereignty, but also have the ability to better review where they are. At health leading organization, WHO has, of course, a role, and we are having a lot of discussion and contribution from professional association, as I mentioned, for kidney disease, for even, condition on skin disease that are chronic. So what goes in the definition of NCD at the global level should not, preclude their inclusion when countries are prioritizing. But again, it's a question of being able to take into consideration the resources, the constraint, and one important element in terms of context is the COVID and the health system resilience and recovery approach that country now have to build on. We have seen how much disruption the pandemic created. So moving from that progressively to restore, but also to think how we can strengthen health systems delivering on NCD prevention and control, I think would be key. So the second part of your question is really around how we support in terms of technical assistance the country to review where they are ahead of the high-level meeting, and there will be a set of high-level meeting organized. I will put in the chat what we intend to do in terms of the road to 2025, and really we are trying to provide most of the assistance in terms of updating the intervention that are the most cost-effective intervention and the NCD best base, but also trying to give tools for country to review their own roadmaps and their ability to look at where they are at the moment in order to prioritize or reprioritize and scale up their response. So I'll put some element in the chat and stop there. I'm happy to take any additional question.
Thanks a lot, Salim. And I think, yeah, just to reinforce a couple of your points there, which were, I think, really important. The point around, yeah, the global NCD agenda being a global agenda, and it's very much up to countries to be deciding, you know, where they focus, depending on their disease burden, their capacity, their resources to be able to respond, as well as the opportunities of universal health coverage and the fact that, you know, UHC and progressive realization of universal health coverage can include a much broader set of conditions and diseases, again, depending on what the country's priorities are. So thanks a lot, Salim, for that. Hopefully we'll have time to go around the panel at the end with an additional round of questions. But you mentioned there in your intervention, and, you know, obviously that certain regions and certain governments are taking a broader approach to NCDs. And now we'll move on to a couple of really important champion governments that are joining us who have done exactly that. And I'll first introduce our third speaker, who is Dr. Clarito Cairo, who is the Programme Manager for National Integrated Cancer Control Programme, and including palliative and hospice care and thyroid disorders at the Department of Health Disease Prevention and Control Bureau at the Philippines government. Dr. Cairo, thanks so much for joining us. And so I wanted to ask you, why did the Philippines include diseases beyond the 5x5 approach that we've been talking about today in your national strategic plan for the prevention and control of NCDs? And what advice would you give to other governments looking to develop a broad, inclusive NCD agenda as you have done?
Okay, good morning, good afternoon, and good evening, everyone. Thank you for inviting me. So I must say that it was by default, because before the Sustainable Development Goals 2016 to 2030, before the global strategies on NCD prevention and control, as early as 2000, we have the program on iodine supplementation. So we have this annual Goiter Awareness Week observance every fourth week of January. And in 2015, when I began to handle the cancer control program, we have our partners, the Philippine Thyroid Association, the Iodine Global Network, and of course the Merck Philippines. They approached me to expand the program from iodine supplementation to thyroid disorder prevention program. So since I'm handling cancer, then we decided to dovetail thyroid disorders on thyroid cancer. So that's the start of our campaign to start this thyroid disorders prevention and control program. And when we have the law, the legislation on cancer control, as well as universal health care or the universal health coverage in 2019, we decided to include thyroid disorders under the cancer control division. So the rest is history. So now it's part of the DOH program, even though it's not part of the NCD 5x5. And I came across an article, all NCDs outside the 5x5 is, I consider as neglected. But as Dr. Slim has mentioned earlier, they're not neglected. But since they have no global strategies, then each member state, like the Philippines, can have our own initiative. That is why we are prioritizing also thyroid disorders, because our partners, they have a strong role to play. We have a strong collaboration with them. We don't want to disappoint them. And as they say, nothing about them without them, right? So our civil society organizations, including all NGOs and the patients, are always involved in the decision making, especially for NCDs, which is something new for the Department of Health. And we need to prioritize it even in the COVID-19 pandemic. So I encourage all governments, especially their ministries of health, to do or to promote participatory governance in NCD policy development and program management, because they really have a role to play. Yeah, that's all. Thank you.
Thank you very much, Dr. Cairo. And yeah, just, I mean, that last point about participatory governance very much aligns with something that the NCD Alliance has been advocating for a long time, which is, yeah, obviously ensuring that we have civil society and people living with NCDs at the table to be consulted on by governments when policies are being developed and services are being designed. And also we have obviously a very important role in accountability as well, in monitoring and accountability and ensuring that these policies and services are delivered and meeting the needs that they're designed for. So thank you for raising that point. And great to hear about the work of Thailand and the importance of thyroid disease in your cancer program. So now let's move over to another champion government, which is, sorry, I realized that I just said Thailand and we were talking to Dr. Cairo, who's from the Philippines. So now we move over to Dr. Paisan Rumvibunsak from the Department of Medical Services of Thailand. Delighted to have you to join us. And the question for Dr. Paisan is really that Thailand has been an important champion of mental health and a pioneer in integrating NCDs into existing public health programs, for example, HIV/AIDS and COVID-19. So we wanted to ask you, what are, according to you, the opportunities and possibilities for governments to develop an inclusive NCD policy agenda?
Thank you very much, Kathy. I'd like to thank the organizing committee for inviting me to this important meeting. It's my pleasure and honor to join. Well, there's a lot of opportunities and possibility for the government to develop the inclusive NCD policy agenda. Well, I'm an eye doctor and I'm a retinal specialist. So I can give you a case example, a model of prevention of blindness from diabetes that we are doing in Thailand. First of all, I'd like to tell you that, well, we have a large population of diabetes, just like any other country in the world. We have 4.5 million people with diabetes, but we have a shortage of ophthalmologists in Thailand. We have only like 1,500 retinal ophthalmologists in Thailand. And based on the survey of blindness back in 1994, we found that, well, the second cause of blindness in Thailand was due to diabetic retinopathy, which is a diabetic eye disease. Well, it's been accounted for like 30% of all the blindness in Thailand. Well, the screening of diabetic retinopathy is very important because you may have bad diabetic retinopathy without any symptoms at all. So we need to have a screening program to detect patients with diabetic retinopathy. At the time, back in 1990s, well, the only strategy for screening was dilated retinal examination by ophthalmologists. We did have a kind of retinal camera to take pictures of retina to conduct the screening, but the camera back then was a kind of film-based camera. It's not really practical. So this has been changed at the turn of the century at around 1999 and 2000, because there's availability of digital retinal camera. With the digital retinal camera, it means we can have a real image of patient right away once you take their pictures. And some camera is even better. You may not need to do dilatation of the pupil. And the camera is very easy to use. And since the retinal images is valuable immediately once you take the photos, we can train like the local non-physicians to take the retinal photos and then read the retinal photos to detect cases for referral to eye doctors. So we conduct a study to show that if we train the non-physicians, the local non-physicians, and use the retinal specialists as a gold standard, we can train them to have sensitivity and specificity to detect referral to ophthalmologists with a sensitivity and specificity like 85%, which is very appropriate for screening. It's not bad, and I think 85% is quite good. So with that study, that we found that, well, they have quite a good sensitivity and specificity if we train them well. We set up these training courses around the countries. We recruit like local non-physician from primary care units from all over the countries to have the training of how to take the retinal images and how to read retinal images to detect referrals. And we built up like many thousands of the non-physician at the primary care level to do this job. And after that, the Ministry of Public Health take over this project. The government of Thailand, especially the Ministry of Public Health, truly support this project, and they set the NCD units of each provincial health office to do this job. So we had after that we had like around like 700 cameras for all over the countries, and not only for the screening side, the government of Thailand also set up this project in terms of treatment as well. We have the kind of like off-label medications that's been used for treatment of diabetic macular edema, which is a kind of swollen of the center part of the retina, which we use for seeing. We endorse a kind of off-label medication that's using for treatment of the swollen of center part of retina. We set them into our national list of essential medication. It means every patient in Thailand with diabetic macular edema can be accessed with this medication without cost. And the treatment of diabetic retinopathy using laser treatment and surgery were also covered by universal coverage by the government. Well, as I mentioned to you earlier, that back in 1994, diabetic retinopathy was the second cause of blindness in Thailand, and it's accounted for like 30%. But from the survey in 2014, we found that diabetic retinopathy accounted for only 5% of blindness in Thailand. It improved quite a lot. And well, and the government implemented 60% of screening of patients with diabetes for retinopathy for the whole country. However, well, this project's been keep going, and then we found that the 60% landmark that the government like to set the bar has not been reached yet. It's been reached only like 50% for the whole country. And in 2016, we have a new technology for diabetic retinopathy screening. We found that artificial intelligence, which is called like deep learning, can analyze retinal images quite well. And the sensitivity and specificity for the deep learning or artificial intelligence is even better than the trained local graders that we train. They have like sensitivity and specificity more than 95%. So since 2017, we conduct many studies. First, retrospective study using images from all of the regions in Thailand to have artificial intelligence to analyze. And then we conduct a prospective study using the artificial intelligence in real time screening of patients with diabetes. And we found that their sensitivity and specificity was more than 95%. So we are in the phase of using artificial intelligence to assist the non-physician screeners in Thailand at the moment. Well, I think lesson learned from this SIS model is that, well, we can apply appropriate technology in each era for doing screening for complications of the NCD. And in fact, well, there's many studies published recently found that, well, the retinal images can be used for screening like chronic kidney disease, hypertension, cardiovascular risk, and anemia, with the accuracy pretty good, like more than like 90% something, which is, I think, well, the retinal images may be a key for screening of NCD and its complication in the future. Yeah, this is what I'm going to share today. Yeah, for the first round. Thank you very much, Kathy.
Thank you so much, Dr. Pyson, and thank you for really highlighting the importance of strengthening primary care in terms of the NCD response, and also the role of non-physicians and the opportunity of task shifting at the primary care level, which is so important, I think, as well as the way that technologies can be applied to multiple different diseases in the NCD agenda. So thank you very much for that. Now let me pass over to our, I think we're on to our fifth speaker. My next speaker is John Gikonya. John is a lived experience advocate. He is also the chair of the Caucus of Patient-Led Organizations under the NCD Alliance of Kenya, which is a member of the NCD Alliance. And he's also a member of the NCD Alliance in Kenya. Thank you for joining us, John. And the question I'd like to ask you is, could you tell us more about the lessons learned from Kenya's success and the important role that people living with NCDs have played in developing the country's national strategic plan for NCDs?
Thank you. Thank you very much. And thank you for the invitation to be a speaker in this forum. And good morning, good afternoon, good evening to all of you. And greetings from sunny Nairobi. Yes, Kenya has not been spared by the scourge of non-communicable diseases. In fact, we are now referring to NCDs here as a pandemic in slow motion. I think we have all seen the COVID-19 pandemic, which is, you can say, is in quick time. And that has elicited a very quick and fast response from every part of the world. But it is not lost to us that NCDs are indeed a pandemic. And though they may not have or bear the urgency of right now, there is every reason that we should pay attention and do and take all the measures necessary to, have interventions to make sure that the projections that we see for the next 20 or 50 years do not come to be true. So our national strategic plan on the control and management of NCD is based on the need to strengthen a comprehensive multi-sector response to the NCD burden, which is growing at a shocking speed, in Kenya and other parts of the world. And this is due to multiple factors like unhealthy diets, air pollution, and which until the past few decades have not been so rampant, and therefore they've not have had such a deadly effect on people like what we are seeing today. Now, the NCD strategic plan in force now, I think, is our second phase, which will be running from last year, 2021 to 2025. And when we came to this, to compiling this second phase, it was clear that because of the many causes which extend beyond the health sector, there was need to involve a highly participatory process with diverse stakeholders like county governments, civil society, development partners, and of course, persons living with NCDs, so that we could bring all views and opinions to the table, and then so that we come up with a comprehensive solution where all aspects and opinions have been accommodated. As persons living with NCDs, we were able to participate in this partly because we were already mobilized under the NCD Alliance of Kenya, and we had also benefited from facilitation of capacity building. And this is critical because you may end up at a table where you're not able to contribute as a patient or a person with lived experience or a patient representative, because you don't have the expertise or the knowledge on how to go about this kind of thing. So we are quite grateful that NCD Alliance was able to prepare us for this and other roles in advocating for NCD control in the country. So we got together, we compiled a list of issues and matters that we thought were critical and needed to be accommodated in this document. And then after that, we selected 2 members from our caucus, who we were able now to send to the Ministry of Health technical working group that's went and sat somewhere for a whole week. And so we were able to contribute in terms of bringing to the table things and matters that we want included, and also in compiling the entire document. So we were happy to be involved in that, and the whole process provided a clearly defined opportunity for people living with NCDs to be a meaningful part of this critical decision making. And I would say that this is a big part of the reason why it was so successful. Also to add that it's not just enough to recognize that people living with NCDs are experts in their own diseases and what they're dealing with. Though it's important, it's a first step, and we need after that to create a place at the table for persons living with NCDs so that they can share their lived experiences, they bring their opinions. And I think this kind of forums do give us an opportunity for feedback, because usually we engage with healthcare workers only when we go for clinics. And this is usually a limited time. And for a patient, it comes at a cost because you are paying to attend clinic. So there is really no forum or opportunity to engage besides, telling the doctor, I'm feeling like this, and the doctor filling a prescription, and you are out so that the next patient can come in. So it is important that we have, this kind of engagements outside of the clinic environment, because then we are able to freely share and exchange our experiences, our expectations, our frustrations, and also give feedback on what is working, what we like, what needs improvement, etc. So this has been a successful opportunity for us. And when we engage the Ministry of Health, I'm happy to say that subsequently, the Ministry of Health actually did include meaningful involvement in the document of the strategic plan. And as we speak, the ministry, in conjunction with NCD Alliance, is in the process of now laying down a framework for engagement with patient groups nationally, so that we can be able to have as many patient groups as possible come to either local, or regional, or even national platforms, and we are able to all share our lived experiences and opinions about what we are going through. And we already have now the Global Charter on Meaningful Involvement, which is a document that will be a very important tool, which will be a roadmap on how these engagements can continue going forward. And so we are excited about this, and we are currently engaged in dissemination of this Global Charter document, encouraging as many stakeholders as possible to endorse it, so that we all move together as people with one common approach to the control and management of non-communicable diseases in the country. Thank you very much.
Thanks so much, John, and thanks for all of your fantastic work in Kenya. And I think the example you just shared there is a fantastic example of participatory governance and the important role that people living with NCDs can have in shaping population-wide policies that governments are developing. So thank you so much for sharing that specific example. We now move to our last but by no means least speaker, which is Professor Leonardis Duntas. Professor Duntas is an endocrinologist and also Secretary of the European Thyroid Association. Delighted to have you join us, Professor Duntas. I have two specific questions for you, and if I could pose both of them and then you respond to both, if that's okay. Firstly, can you tell us a little bit more about the role that endocrinologists and health professionals in general can play in the development and implementation of this inclusive NCD agenda that we're talking about today? And also, I understand that the European Thyroid Association formulated a petition to the European Commission stressing the need to recognise thyroid disease as a specific NCD. So what advice would you give to other organisations seeking to advocate to their governance for inclusive NCD policies? Thank you.
Thank you very much, Kathy. A warm greetings to everyone, everywhere. I would first like to congratulate all those who have initiated and organized this event, whose purpose is of utmost importance, namely to tackle what has been called the 21st century biggest health threat, an endeavor that needs to strive to respond to all non-communicable diseases inclusively and equally. Today, NCDs are worldwide the commonest causes of mortality and premature death, while also producing high levels of disability among those affected. As an endocrinologist, I believe that we have the responsibility to disseminate full and updated information to the authorities that will enable radical action to be taken to reduce NCDs as effectively and as speedily as possible. More specifically, we must go to the source, to the roots of the problem that put pressure on authorities to implement measures so as to decrease those widespread risk factors for NCDs stemming from imprudent lifestyle habits and including unhealthy diet, tobacco use, harmful use of alcohol, physical inactivity, and air pollution, thus better addressing the needs of people living with NCDs. Thyroid disorders being among the most widespread medical conditions with a high prevalence, varying depending on age, sex, the definition of disease, and availability of iodine. Iodine is the main cause of endemic goiter and hypothyroidism, an issue of extreme concern for 1/3 of the world's population who live in iodine deficient and depleted regions. Based on these facts, the World Health Assembly passed a resolution in 2010 calling upon the World Health Organization to aim at eliminating iodine deficiency. This objective is particularly pressing since although iodine deficiency is the main cause of endemic goiter and hypothyroidism, additional environmental factors such as selenium, iron deficiency, pollution, stress, smoking, and obesity are increasingly involved in the pathogenesis of thyroid diseases. Moreover, the two thyroid diseases, the main thyroid diseases, hypothyroidism and hyperthyroidism, have increasingly been associated with hyperlipidemia, atherosclerosis, arterial hypertension, risk factors for cardiovascular disease, but also for arrhythmias and Alzheimer's disease. It is thus evident that thyroid disease may impact on the outcome of certain other non-communicable diseases, thereby increasing the patient's burden of disease, as well as the risk and outcome of comorbidities, while also increasing his own and the state's economic burden. It is hence our firm belief that thyroid diseases must be recognized as non-communicable diseases and include the 5 major diseases namely overt and subclinical thyroid disease, hypothyroidism, hyperthyroidism, autoimmune thyroiditis, and thyroid cancer. Caring for people with thyroid disease and non-communicable disease is nearly an emergency, as thyroid disease, as said previously, particularly the autoimmune thyroiditis, is the most common endocrine disease. This statement forms a request to the European Union institutions, particularly the European Commission, to take firm action on NCDs by establishing an European Union strategic framework for the prevention of non-communicable diseases by 2030. But it is also a call of the European Thyroid Association to have thyroid disease recognizing as NCDs. I venture to offer some advice to other societies seeking to request their government to implement inclusive NCDs policies, namely suggest the active adherence to the European Union strategic framework for the prevention of NCDs and establishing synergies with various policy areas such as those tackling health inequalities, adopting a rights-based approach, and implementing the WHO best buys. I think that it is all that I have to say, and thank you very much again.
Thank you so much, Professor Duntas, for that intervention and for sharing the specific example of how the European Thyroid Association have been advocating with the European Commission on this important issue. So this brings us to the end of the panel, opening introductions and statements. And what we want to do for the next 10 or 15 minutes is to respond and ask some of these questions that have been coming in from the Q&A. So thank you to all participants for posing fantastic questions. Let me start by with a question that was specifically directed to Dr. Slim Slammer from WHO around NCD funding. The question was, why can't the funding of the NCD response be similar to that of HIV/AIDS? Given HIV/AIDS started very well with good funding, and hence there's been a lot of progress over the last couple of decades on it. Do you want to start with that one, Dr. Slammer?
Yes, thank you. I mean, Katie, yourself, you have been at the forefront of those global discussions, but I think we will not, personally, I don't believe that we will have a new global fund for NCD. For various reasons. One is the ability to create, like we always do in global health, a cohesive narrative on NCD. And the example of today about what is NCD, what are the range of conditions that will enter into that inclusiveness, I think it's a challenge in itself. And I'm not sure that on that, I mean, having malaria, tuberculosis, HIV is much more circumscribed as an agenda, and I think have leverage. The other aspect is who are the players that are driving the NCD. When we call for something in global health, you need to have coalitions and policy networks and people raising and defending those causes. And I think in the HIV field, clearly we have seen it, it was strongly led by communities, by people affected themselves that were asking actually as a human right perspective. We won't probably have that leverage. We tried several times on the NCD agenda. And there was also a context of where we are with the UHC. The analysis of healthcare financing is that we can no longer rely on external funding for domestic health issues. The primary focus should be on how to mobilize domestic resources with catalytic funding. And this is where actually most of the scheme at the moment, and you have multiple examples that are being discussed, a multi-donor trust fund approaches. We have seen it also with the post-COVID. All these are catalytic funding. And we have seen also, I think, bilateral donors. We have example with Norway and Scandinavian countries that have, in the recent 5 years, put considerable resources for 5 years plan on NCD. I mean, in Africa, we have example with Ethiopia, with Ghana, with Nepal, Myanmar, where basically those funding are really topping up on the domestic resources. But I think is first the countries are in the driver's seat, looking at what they can do themselves in mobilizing additional resources with catalytic funding. But clearly, I don't think that we will see emerging in new NCD fund, and I don't think that even it should be the solution.
Thanks, Dr. Slama. And let me bring in this second question that's come in from the Q&A, which I think is a really good question, which is, what advice can we give our governments, it was specifically from someone in Nigeria, I think, what advice can we give our governments in Africa to move from papers and policies on NCDs to proper implementation? And I think this very much builds upon mention from Andre at the beginning about the challenges of implementation on the ground. So let me pass over to perhaps Andre, you want to start us off, but others please jump in.
Reid, can you hear me first? I put a headset on. Yes.
Perfect.
Yeah. Implementation, it's a tough one. I actually don't know where to start here. So one of the things that we're looking at, as I said earlier, is how we can assist primary care physicians in the awareness, education, etc. So that's something that the company that we're actively doing, and that's something that we can do. And we're as working with local governments in countries. So how we can work private-public partnerships together with one objective is the outcome for the patient. So it's not a one-size-fits-all because every country is slightly different. But if I can talk what I mentioned earlier around implementation in emerging markets generally, there's a lot more work needed to be done there around education, awareness, government understanding, impact of the total healthcare system is important, and that's a knowledge, and that goes back to the other point around statistics and the impact of this and the comorbidities around just the thyroid disorders as well. So just some of the comments from my side.
Do others on the panel want to jump in on that question as well, around the kind of challenges of implementation at the country level? Yeah, Dr. Slama.
Yeah, I think it's inclusiveness is also the sense of ownership, and we have had example with John in Kenya, and I was responding in the chat to the colleague from Nigeria. If you want to create accountability, I mean, start at your country level. I mean, the NCD Alliance, all the role of the NCD Alliance at the country level is also to maintain that strength of the communities to mobilize on participatory governance, on prioritizing the agenda in the right way, in maintaining a bit of that pressure. I mean, Thailand have even institutionalized it at the level of the country in having this health assembly, basically where people can really voice their concern, maintain, I mean, that momentum. So creating that kind of democratic processes is really key. And this is what the NCD Alliance had mentioned. Then, of course, you need to have evidence and knowledge, so that the discussion are really informed and are tailored to the context. This is what I was responding to the colleague in the chat, is that you need to tailor it to the level of Nigeria, and it's a huge country, and what is feasible there maybe is not feasible in other countries, and so forth. So this is where I think I see really the vibrant communities. I think some of the regional workshops that you have organized, also the NCD Alliance, were very interesting in how we mobilize this along action plan or something concrete that are palatable. A last element that I think we haven't really focused on at the global level is implementation science, is the how of things. How in any project we can embed implementation science to understand what works, what doesn't work, what is actually work in one country, not in another. I think that part of the research prioritization agenda on implementation is really something that somehow has been missing out.
So yeah, I agree with Dr. Slim and Andre totally. I think the examples of the government of Thailand that can implement some of the policy quite well, because I think we set up a lot of key performance indicators, and we keep monitoring all those indicators extensively. Well, I think we actually have a website called like HDC or something, for it means Health Data Center from Thailand. You can actually get into and trace the kind of, for example, the percentage of patients with diabetes screened for retinopathy or screened for other complications. It's been live on website, I think this is how the government of Thailand monitoring all these important indicators, and it's going to help a lot for implementation, I think.
And perhaps let me ask just a follow-up question on that, because I think a common thread throughout our conversation today has been the importance of evidence, of data, which can help inform countries set their own priorities. I guess my question would be kind of, where do you see the priorities in terms of strengthening data and surveillance for NCDs at the country level to particularly ensure that we've got strong data on NCDs beyond the big 4, big 5, as well as the kind of challenges of multimorbidity?
Katie?
Yes, Professor Dantas, go ahead.
Yes, I think that it is very important to stress a more close national and international synergy, collaboration, and improve our solidarity. The primary role and responsibility of governments in responding to this challenging of NCDs may stress our implementing efficacy in preventing the strategies, empower the community, invest more to the prevention of the factors that influence the NCDs. Because I think that together we will have a more international cooperation, and the collaboration will be more productive than its agency or its government or its nation alone. It is a world threat, and only a world collaboration can tackle this threat.
Thank you. And Dr. Slammer, do you have your hand up?
Yeah, I mean, you know, we also sometimes in the NCD community tend to be very restrictive in our views. Everything becomes an NCD. And actually, as I mentioned, we are in a UHC agenda. We are in a sustainable development goals. We need to keep track on what is the big ticket issue that, and in surveillance, I put them in the SCORE framework. The SCORE framework is a framework that has been developed in the context of the SDGs to really look at what do we need really to measure on health data at large. And they cut across, I mean, many interventions you can add. Some aspect are population level survey to look at risk factors like the steps that we have, but beyond that, the other aspect is the ability to count birth and death and attributable death related to NCD as part of other agenda. The ability now to move, as we were discussing, when we were in discussion with Thailand recently after the executive board, when we put the diabetes target, and some of the member states were saying, oh, is it possible to measure it? And Thailand was a perfect example. They were able actually to look at the cascade. Who is diagnosed, who is under treatment, who is covered, and reaching, I mean, performance indicators in terms of coverage. And this is one part of it. And then how you review the progress and the performance across a national program is another element. How you use data for policy information. These are the elements of the SCORE acronym. I think this is where we need to invest. And sometimes we tend to really reduce it to the NCD agenda. For me, that inclusiveness is also to be intelligent of what is wider than your own programmatic areas and how you can have an entry point there, because actually this is probably not the tree, but the forest that you need to keep ahead.
Thank you. And let me bring in John here.
Thank you. I'm responding to the question from someone in Nigeria in terms of moving government from rhetoric to action in response to NCDs. And I would like to give an example of a case in Kenya. I'm a kidney patient myself, living with a transplant, and we do have a program now with the National Health Insurance Fund where the government, through the National Health Insurance Fund, pays for dialysis 2 sessions a week for all people who have kidney disease in Kenya and have prescribed with subscribed with the National Health Insurance Fund. Now, how did we get here? It was simply a case of fervent, incessant advocacy and activism. Patients mobilized and went and knocked on all the doors. We went to the minister's office, we wrote to the president, and it took quite some years. And actually, some of the people who were very active in starting this off were not alive by the time we realized what we were looking for. But sometimes governments only prioritize areas which have some noise around them or some focus. So if you as a movement of patients or either NCD patients or any other condition are able to organize yourselves and keep pushing, keep knocking, keep calling, and again, like somebody has said, make sure that your activism, your advocacy is backed with facts and figures. I think you'll be able to move a government. Another aspect of meaningful involvement, again, is that when you work with policymakers, as a patient representatives or patient groups, you start now seeing things from a common point of view. As a patient, you're also able to understand the limitations and the competing interest in some of the things you're pushing for, but you will be able now to approach things from a common understanding. And that eventually bears fruit because you're dealing with things that now you fully understand from both sides, from the recipient, that is the patient, and from the people who you're pushing for action, that is the health authorities in your country. So advocacy is what I would say is the way, one way of pushing government from rhetoric to action. Thank you.
Thanks, John. And perhaps I'm a little bit biased, but I would completely agree with that statement in terms of the importance of civil society and the importance of people living with and constant advocacy to keep the issues high on the agenda. Andre, I've seen that you've got your hand up. Do you want to jump in?
I was going to say I thought what John just said was actually brilliant. And I think sometimes it's they who shout the loudest wins, right? And I've worked in many therapy areas over my time working in the healthcare sector. And if you look at, say, oncology, they're very sophisticated with the noise, with the advocacy, with the governments. They have hard data. And I think what we lack in, if I could say, the thyroid area, and I also, as you know, work in diabetes and cardiovascular in my therapy area, we have a lot of data there. But I think in the thyroid area, we lack a lot of data, hard data. Like I've got directional numbers on the prevalence and then the treatment and diagnosis and treatment in many countries. We lack so much. Now, if we don't get this data, then I can't, you can't go to governments and put a really good story together. And then what is the health outcomes if we don't do anything? If I look at the oncology, I use oncology as an example, there's very, very clear data and outcomes. And I think this is where we need a very coordinated story on the back of very clear data. And we need to invest that. Then the advocacy, as John's saying, is going to actually work. Then we can influence governments to invest. Right? I just don't think we've got that yet. And I think this is why if we could really raise the importance of thyroid disorders on the back of really good data, that's when we can really make the difference. And then, John, you're right, advocacy, it will start to turn the wheel. Thank you.
Absolutely. And I think what we've learned in NCDs over the last 10 years or so is also the importance of economic data as well, because we've always said that you need kind of messages and data for the head, for the heart, and for the pocket to really influence governments. And the data on kind of the investment case, the economic impact of diseases has a huge impact for ministries of finance as well as ministries of health. Slim, I'm going to come to you last because I've actually got a follow-up question for you to finish us off here, if that's okay. There's a question here that we received that can the WHO help us with the recognition of thyroid disorders as an NCD, even if the funding and the policy actions on NCDs come from country level?
Yes. Well, I was actually responding to Isabel privately, but actually I wanted to raise that point because building on what Andre just mentioned. I mean, we have a global strategy that is somehow current on the 4x4, but as I said in my remarks, it doesn't mean that we are neglecting all the rest. I'm on a daily basis receiving contact from different professional associations on specific conditions. They are constrained from a WHO perspective as somehow a global health advocate to have resources ourselves to dedicate staff. Sometimes if you don't have a staff, just to give you an example, on diabetes, we have 2 staff or 3 staff in HQ level, and sometimes we don't have representation in the region. So this is what member states also are giving us a mandate, but we don't necessarily have the full resources to advocate. So to be able to advocate, you need to have resources. But even though we have an example, I mean, I was giving the example to Isabel in the chat, psoriasis, 60 million population with psoriasis in the world. It's totally neglected. We have even a WHO resolution on it in the past, but there is no work on skin diseases that are chronic like psoriasis. What we did is with the association, they reached out to us. And I told them, okay, you have a report. There was even a publication on psoriasis that was a WHO report. So you have something, you have a resolution, build on it. One of the points is what Andre mentioned, build your data. You don't have necessarily to rely on WHO. There is, I mean, people are referring to IDF for diabetes or the health metrics on the burden of disease. Start somewhere, getting your data right, try to inform policies with showing the burden. And there are various elements. I mean, you mentioned the economical impact, but also solutions, not only the problem, but what has been done in countries in integrating this agenda and trying to link it to the NCD, even if by default it would probably never be linked to the global agenda. For me, there is always solution. It's just that we need to be somehow creative in how we advocate for this and how we can link it to the global agenda. The UHC approach, as I mentioned, is an entry point to address all those needs beyond the NCD1 that are being addressed. So I think the palliative care work, I come from 8 years in the region in the EMRO, we mobilized people in countries that were champions on palliative care. We didn't wait to have a global mandate to do it. And actually through that mobilization of national networks and advocate, we start, I mean, looking at curriculum, at guidance and guidelines and access to medicine, opioid policies, and progressively, I mean, opening up this agenda. So there are, I think, entry point are the people matters first, and the people from the countries and the region are really at the forefront of this advocacy work. Over.
Thanks so much, and thank you all for joining us today and for your fantastic interventions and perspectives throughout this this session today. Let me try and summarize what we've covered in the last hour. I think for me, some of the key messages that have come out of the conversation is that we need to look at the global NCD agenda as a global agenda, and that not one size will fit all countries, and it's really up to countries to be tailoring their response based upon their burden, their priorities within their national NCD plans. Secondly, that there are multiple entry points to be ensuring that we accelerate an inclusive NCD agenda, and universal health coverage is one of those, given that there's so much political capital around UHC at global and country levels, and many countries are developing their national UHC responses, and NCDs should obviously be a part of that in terms of the benefit packages that countries are implementing. Thirdly, another entry point that one of our panelists mentioned during the conversation was COVID-19 and pandemic preparedness and response. And I think obviously the links between NCDs and COVID have been extremely clear over the last 2 years. And governments are now building back in terms of their health systems, and priorities in terms of pandemic preparedness and response are shifting, with an opportunity to include NCD prevention and control within that agenda. So I think that's another entry point that we should all be thinking of. And I think throughout these conversations, many of our panelists have really spotlighted specific solutions that we should be focusing on. And I think the first set of solutions were around evidence and data, and the importance of having national country-specific data to inform national plans, as well as ensuring that we're using that data to develop a clear and compelling narrative for advocacy, and that the data get into the hands of advocates and governments and policymakers alike. The second set of solutions that I think we covered were around health systems and how to ensure that our health systems are oriented to a broad set of NCDs, and the importance of raising awareness of healthcare professionals, the role of non-physicians, and the importance of strengthening, particularly at the primary care level, as well as the importance, again, of data within health systems, I think came out very clearly. And I think the third set of kind of solutions that we covered were more around kind of policy and advocacy opportunities. And I think at the end there, Slim highlighted the importance of champion governments within this. And we've been really honoured to have 2 champion governments in this panel, Thailand and the Philippines. So thank you so much for joining us and sharing your experience of how you're translating inclusive agendas at the country level. But also at policy and advocacy level, we've talked about the importance of participatory governance and the role of people living with NCDs, as John has so eloquently articulated throughout this session, and the importance of advocacy that links the specific disease that we're working on to the broader set of policies that already governments or WHO are working on, and the ways that we can incorporate our issues into policies and funding opportunities that are already there. And I think another point that was raised by multiple different panelists was this importance of broad-based coalitions and alliances for advocacy, because I think whenever we look at any success story in global health or sustainable development, there's always been a very strong base of a coalition that's been driving forward that specific agenda with a very clear common agenda and common priorities. And then finally, just to end, I think near the beginning, we highlighted the importance and the urgency for action with the UN high-level meeting on NCDs in 2025, only around the corner, and also that being a landmark moment for the fact that governments should be achieving their 2025 WHO global NCD targets, as well as the Sustainable Development Goals as well being just around the corner. So I think there's a very clear imperative for action. There are very clear milestones that we can all be working on to ensure progress on NCDs and an inclusive agenda particularly. And thank you again to all of our speakers that have joined us, and a particular thanks to Merck, our co-host and partner in this event. Thank you all, and have a good rest of your day. Thanks very much.
Thank you. Thank you.
Thank you very much.
Goodbye. Thank you for the
Thank
invitation.
Thank you.